Hi, I'm Emilio Fumero, Global Medical Director in Beef Healthcare. What I would like to discuss with you in the next minutes is to explore and review the complex scenario of drug-drug interaction in HIV setting. What I would like to do in the next 20 minutes or so is basically first to describe how frequent is this problem, to understand how is the evolving epidemiology in the current HIV era, and lastly to basically discuss potential factors that may help us to understand the potential drug-drug interactions that may happen in HIV or older patients. So if we review the literature, we can find an important list of reports that look at the frequency of drug-drug interactions in real-world data. And overall, the frequency move around 20 to 40%. However, a few of these studies also explore what is the clinical impact of those drug-drug interactions, either in HIV or in any other condition. And you can see that few of them, if they report, they basically look at the potential effect on viral control, but none of them report on the safety side. In a very large cohort, an American cohort looking at roughly 4,000 patients, similar that we have seen in the list of the different cohorts, the rate of this situation of potential drug-drug interactions moving from moderate to high-risk interaction is roughly 30% in those patients. But strikingly, 10% of those interactions are considered as highly contraindicated, and most of them are driven by frequently used concomitant drugs such as proton pump inhibitors or lipid-lowering agents. So it's a frequent problem. That situation will not wane over time, will be the other way around. Currently, in every hospital in Europe, roughly 1/3 of our HIV patients are 50 or above 50 years old. And that situation will increase over time in a way that by 2030, more than 60% of patients will be about 60 years old. And this will pose a substantial challenge to manage. Several cohorts have reported that that situation is combined with a frequent combined comorbidity that we used to see in HIV non-infected patients usually 10 years later. So it's situations that happen early on in advance and usually happening with two or more comorbidities. So it's a frequent phenomenon, it's a very complex phenomenon. That situation may explain why in this cohort the frequency of patients that are receiving more than 5 concomitant drugs is substantially higher than in non-HIV population. And when we look particularly in those drugs that are not HIV related, we can see that situation start to happen more significantly in those patients that are over 50 years old. When we look at what exactly are the drugs that are involved in these drug-drug interactions, not surprisingly, we've seen that those are related with cardiometabolic problems, lipid-lowering agents, cardiovascular drugs, diabetic or metabolic drugs, etc. That drugs are frequently used in over 50 years old, but that happens more frequently in HIV population. We need to remind that some drugs in the cardiovascular arena pose more complex situations than others, and that is particularly true for antihypertensive drugs, particularly those related to the family of calcium channel blocker. We need to extreme caution and bring a lot of alert of the potential drug-drug interactions with antiretrovirals, because either by the principal drug or by the metabolite, that could drive into sustained and severe hypotension. The other well-known situations is the potential drug-drug interactions between antiretrovirals and lipid-lowering agents. Certainly, the most common use is atorvastatin, which is fairly safely used with the majority of antiretrovirals. However, we must pay a lot of attention about the potential new statins in combination with new antiretroviral agents. But the situation which is becoming more and more complex is when we deal with drugs that we are not certainly familiar with. And I'm referring to drugs that either they're looking for control of anti-aggregant drugs or anticoagulant drugs. And the control and the therapeutic windows of those concomitant drugs, since most of them are very narrow, we need to pay extreme caution and we need to be very aware of the potential drug-drug interaction. So with that, the majority of boosters, the majority of drugs that inhibit C450 may drive to a substantial and potentially serious drug-drug interaction with new family of drugs. Let me give some consideration. Let me explain and talk about some considerations that happen in patients that are getting older. Many changes, physiological changes happen, particularly in the gastrointestinal system, starting for the gastric and gastroduodenal area. We may expect that patients increase pH, that decrease the motility of the upper section of the gastrointestinal tract, and that may drive to a reduction in the absorption of many drugs. And this is particularly true for boosted PIs and, for instance, for rilpivirine. On the other hand, it also has been described a decrease in highly important metabolites and highly important enzymes. They're extremely important in the metabolism of most of these drugs. And that, for instance, may explain the increase in the plasma exposure of some drugs, potentially PIs, some PIs, and many others. It also is well known the decrease in the function of the liver, and not only related with the enzymes, but also a decrease in blood flow that may drive to a less circulation into the liver with the related drug. And in the kidney, it is well known that over time, the glomerular and other functions are reduced, and this is particularly well known that in patients over 50 years old, that function is steeply decreasing. What that may impact, what that may means in terms of the management of our aging HIV patients. Well, we know also that this is not only related on age, but it's also related on the health status of those aging patients. So we've seen a substantial reduce in fit older people, people over 60 years old, where there is an decrease in the clearance of the drugs around 30%, but that could increase up to 80% in patients that are frail and old. This example has been well described in non-HIV drugs. This is particularly for a drug that is primarily metabolized by the liver, paracetamol, but we may expect that some of these changes may also happen in the HIV setting. When we look in particular to antiretroviral drugs, it had been reported initially with lopinavir a substantial increase in the plasma exposure, roughly 40%, but also that is true for darunavir. Recent data have been shown that increase in plasma exposure of darunavir in patients over 60 years old is happened regardless of gender and regardless of weight and other factors. Although the levels of efavirenz had not seen that increase substantially in all patients, what we have seen is that the unbound fraction significantly is higher than younger patients. What that it means in terms of potential clinical events, we don't know, but certainly that 30-40% of higher unbound concentration may drive to some side effects. It is well known, and that has been consistently reported by many groups, an increase in the tenofovir plasma concentrations in patients over 60 years old, in a way that 20-30% increase. We don't know exactly whether that may drive to an increase in renal side effects, but certainly may pose a situation with, in combination with other drugs, that may increase the risk for substantial drug-drug interaction. It also has been reported that this is not a change that happens with age, but in particular in women with changes in the hormonal status. In menopausal women, the concentration increased substantially, could increase double the exposure of the drug. We don't know again what that means at mid and long term, but certainly it's a data that we need, and we need to pay a lot of attention. When we move and we look at the integrase inhibitor, the data that we know so far basically are quite recent, and it's basically related to 2 out of the 3 members of the integrases. And we know that it had been reported in a cross-sectional study that it had not seen a substantial increase in the trough concentration of raltegravir, and a more in-depth PK analysis comparing control young patients with patients over 60 years old, we have seen a slight increase in the maximum concentration of dolutegravir. However, the overall exposure is exactly the same than young patients. So it is not expected as substantial changes in the plasma exposure and the drug-drug interactions in older patients with these 2 unboosted drugs. So in conclusion, regarding the antiretroviral therapy, it is expected an increase in boosted PIs. It had not seen any major side effects in regard to the increase in the concentration of darunavir. However, this had been tested for the standard dose of once a day. However, we don't know what may change when the patients will use the full dose of 600 milligram BID for heavily experienced treated patients. We don't know exactly what means that increase in plasma concentrations of efavirenz. We need to warn the attention of that increase in tenofovir over time, not only because the natural decrease of the renal function, but the potential increase in risk of drug-drug interaction with an exposure, overexposure of tenofovir in plasma concentration and in tissue, renal tissue. As we expect, unboosted drugs, antiretroviral drugs, may not drive to potential drug-drug interactions since raltegravir and dolutegravir are primarily metabolized by glucuronidation. It is expected few and non-limited drug-drug interaction. I would like to end up with some cautions with frequently used concomitant drugs. Most of the drugs are highly used as an over-the-counter, and this is what I would like to call be aware of the unexpected. In a small cohort of patients that had been used a non-steroidal anti-inflammatory drug, in this case diclofenac, it had seen that some proportion of patients that had been receiving tenofovir containing regimen, it had been observed an acute kidney injury, particularly acute tubular necrosis, and it's a severe condition that may drive to renal insufficiency at the end. So interestingly, what we know is that diclofenac is a selective inhibitor of one of the transporters that happen to pump out the tenofovir out of the epithelial renal cell. So it is expected an increase in the intracellular concentration of tenofovir that it may explain that serious adverse event. So we need to warn and we need to be cautious of what concomitant drugs our patients are using. You can find plenty of reports in the literature of the concomitant use and the potential drug-drug interactions driving to severe adverse events of the use of steroids and boosted progress inhibitors, and in general, CYP450 and CYP3A4 inhibitors, any booster in general. You can find many reports of iatrogenic toxic steroid overexposure driving to Cushing syndrome or osteoporosis. And we need to bear that in mind because in any form and any clinical use of the steroids may drive to these drug-drug interaction. Keep in mind that almost all the steroids used in the human pharmacopoeia are metabolized by CYP450, so it is suspected a high and sustained level of drug-drug interaction. So be aware of the unexpected. So in summary, aging is an evolving and very complex phenomenon that we exactly don't fully understood in the HIV setting. Drug-drug interactions will not go away in any form, will be the other way around, will turn more and more complex. We need to pay a lot of attention and capture and note every single concomitant medications that our patients are taking and review frequently that list in every single visit. It's important to consult to any drug-drug interaction, either in those available tools that we have as a website or in a technical advice with the pharmacist expert. We need to potentially try to avoid those concomitant drugs that may have drug-drug interaction with the antiretroviral therapy. But if that is not possible, remember that there are some drugs that are not metabolized by oxidation and they drive to few drug-drug interactions such as dolutegravir and raltegravir. Thank you for your attention.
Hello, everybody. Welcome from GSK House in London. My name is Jan van Lunzen. I'm a infectious diseases specialist. I used to be the head of infectious diseases at the University Medical Center in Hamburg in Germany. 18 months ago, I joined ViiV Healthcare as a global medical director, and I'm very happy to discuss today some of the special issues about drug resistance development with a special focus on dolutegravir. So having said that, this is my disclaimer. Obviously, I'm a full-time employee of ViiV Healthcare, and whatever I say, I do say as an employee of ViiV Healthcare, although I remain a treating physician at the bottom of my heart. So let me start with a case report, which some of you may have seen already in your clinic. It's a 20-year-old MSM presenting with acute retroviral syndrome. So he came in with malaise, fever, rash and a pharyngitis. On examination, we could see an oral thrush and a lymphadenopathy, which suggested that this could be a primary HIV infection, especially in view of the fact that he had recently a high-risk contact in a club in Berlin about 3 weeks ago. He tested negative 1 year ago, and since then he reported about irregular condom use. In the lab results, we could see some mild anemia and a slight thrombocytopenia. The liver function tests actually were 1.5 times upper limit of normal. Otherwise, the normal routine labs showed no abnormalities. He tested immune for hepatitis B, and he was antibody negative for hepatitis C at that time. Now, since we have suspected that he could have a primary HIV infection, of course we did an HIV antibody test. The ELISA, as expected, was negative, but P24 antigen test was positive, and in the Western blot we could see one band only expressed, which was against the P55. So the HIV PCR was showing a very high viral load of 10 million copies, consistent with a primary HIV infection. CD4 count at that time was 340, and the CD4-CD8 ratio was decreased to 0.4. Now, the patient was immediately started on a tripla. Symptoms got better within 7 days only, and he tolerated the antiretroviral therapy reasonably well, had some mild CNS side effects initially, which waned over time. After 4 weeks, he reported back to the office, showing a decrease of viral load to now 18,000 copies. So it's more or less a 2.5 log drop, which was quite nice after 4 weeks. And CD4 count began to increase to 540 cells per microliter. The other routine lab tests were all normal. He continues his normal life. He is full-time employed and admits to party on the weekends. So we did intensive counseling on safer sex behavior, especially in view of the fact that this patient has recently been involved in a high-risk situation. But patient admitted still to forget condoms once in a while during his party life at the weekend. So the patient comes back after 3 months. Viral load decreased again to 700 copies per milliliter, and the CD4 count increased to 580. All the routine labs again were normal. He reports good adherence to medication, and he received no other co-medication, and now he reports that he is stably engaged with an HIV-negative partner. Now the patient comes back now at month 6, and much to our surprise, viral load increased to 120,000 copies per milliliter, and the CD4 count slightly dropped. The rest of the routine lab were all normal, and he reported reliably a good adherence level of above 95%. So we wondered what has happened, and what we did is we ordered a genotypic resistance test showing the 65R, the 184V, and the 103N mutation, which are mutations typically occurring after exposure to tenofovir, FTC, and efavirenz. So we asked ourselves what may have happened, and what we saw is that when we got back and reviewed the chart initially, that the initial genotype, which we have actually missed in the time between initiating the therapy and the patient coming back at week 4, that there was already a 184V and 103N mutation detectable, indicating the transmission of already a partially resistant virus, which happens once in a while, especially in the high-risk population. Now, what does it tell us? What it tells us is that different things and lessons we learned from this case. First of all, you should always get back and review the genotype which you have done before you have introduced antiretroviral therapy in a naive patient, even in this situation, because we know that transmission of drug-resistant variants can occur. Secondly, it also shows that perhaps we should take into account the barrier to resistance of a given drug combination, especially in view of the fact, even in naive patients, in view of the fact that we may have some transmission of drug-resistant viruses even in primary HIV infection without having been exposed to any of the drugs individually. So the question was then, with a failure with resistant mutations 65, 184, and 103, what is the best treatment option for this patient? Would it be ripivirine dolutegravir, darunavir boosted, raltegravir atazanavir boosted, maraviroc and an integrase inhibitor, maraviroc and a boosted protease, or a double protease inhibitor, or any other medication? I'll leave it to you to decide. There is certainly more than one valuable option. We chose to switch this patient to dolutegravir ripivirine, which is now the drug combination which has been tested in the SWORD 1 and 2 studies, and the viral load suppressed to less than 50 within 8 weeks after switch to dolutegravir. Okay, so this brings me now to the second part of my talk. So what are the goals of antiretroviral therapy in the year 2017? I think it has not changed too much over the past decade. Obviously, we want to reduce HIV-associated morbidity, prolong the duration and quality of survival, which is paramount for the patient. We want also to restore and preserve immune function, to maximally suppress the viral load for a sustained time, and on top of that, to prevent transmission. To achieve these goals, strict adherence to ART is key. as is viral susceptibility, as we have seen in the case which I've just presented. Now, drug resistance, especially transmitted drug resistance, can severely reduce the therapeutic choices for HIV patients, as you see here on this study, which indicated that virologic failure at month 12 occurred significantly more often in patients who have been infected with a drug-resistant viral strain up front. Actually, the virologic failure rate increased from 4.2% after 12 months without transmitted drug resistance fully susceptible virus up to 15%, so fourfold, for patients who have been infected with a somewhat transmitted drug-resistant virus, which was statistically highly significantly different. This may severely limit our future treatment option, of course. So what has changed in the recent guidelines in HIV treatment? The evolution of HIV therapy is summarized on this slide, beginning in 1987 when we used to combine nucleoside analogs. So combining one or two were certainly not a very good idea due to the rapid development of resistance and antiretroviral therapy failure. The real breakthrough came in the mid-90s when we combined two nukes and the third drug, at that time being a boosted protease inhibitor, which eventually led to the durable activity which we're seeing today. Another milestone in HIV therapy occurred in 2007 with the approval of the first integrase inhibitor, raltegravir, and the subsequent inclusion of integrase inhibitors as one more option of a third agent. Now, the basic recipe for initial antiretroviral therapy, however, has not changed very much since the mid-90s. The recipe is still to combine two nucleoside analogs with a third drug. And that can be either a boosted protease inhibitor, could be an NNRTI, or an integrase inhibitor. Now, the evolution of HIV therapy, which is summarized on this slide, indicates that there has been a lot of development in the, let's say, in the third agent segment, which is indicated on the upper, above this x-axis on the graph, where you can see that especially recently we have seen the licensing and approval of a number of third agents, including newer agents belonging to the integrase inhibitor class, and very few actually new things happening in the nucleoside analogs. So the question is, what is the optimal treatment for HIV patients today? Now, what are the current challenges in HIV treatment which we have to consider in an evolving HIV patient population, especially in view of the fact that our patient population is significantly getting older and older? So clearly there are issues about tolerability, there are issues with convenience of a drug regimen, but I would like to concentrate for this talk on drug resistance and on the genetic barrier or the barrier to develop drug resistance overall. Why is that so important? It's important because failure with drug resistance clearly potentially reduces the future treatment options and is therefore of paramount importance for the patient's life. Now, most third agents are unable to meet all challenges. So either there are some tolerability issues, some convenience issues, we have drug-drug interactions, and finally we do have drug resistance, and as I said, we do have regimens with more or less high barrier to develop drug resistance. And especially we know that NNRTI-based regimens, but also the earlier integrase inhibitors like raltegravir and elvitegravir do not have a very high barrier to drug resistance, at least in comparison to boosted PIs. So where is dolutegravir placed in this arena? We do see that we have considerably increased the efficacy of our regimens, which continue to rise from in a meta-analysis above, three-quarters of patients achieving the ultimate goal of being non-detectable viral load in the years up to 2010. But today, 48-week results show that we could considerably increase this rate to above 90%. And what you can see here on the y-axis of this slide is a number of recent trials, licensing and registrational trials, which all have one thing in common. What they have in common is they all include an integrase inhibitor. And I think it's fair to say that the inclusion of integrase inhibitors in first-line treatment has considerably increased the likelihood to suppress viral load to less than 50 at 48 weeks in these registrational trials. Now, dolutegravir has actually shown superior or at least non-inferior efficacy. It has shown superior efficacy in naive patients in 3 comparator studies, superior activity against efavirenz, superior activity also against darunavir boosted, and non-inferiority in direct comparison to a raltegravir-based regimen. If we go then and have a look at the recent guidelines, and I've just picked 2 of them, which is the DHHS and the IAS guidelines on first-line treatment on this slide, we can see that clearly integrase inhibitors represent the majority of recommended core agents. So you should treat nowadays a patient who is naive to antiretroviral therapy, either with any of those integrase inhibitors, dolutegravir, elvitegravir, raltegravir, or with a boosted PI being preferred choice, darunavir. So what is new is that the NNRTI are missing here, and that means that they have been replaced by and large by integrase inhibitors. Now, let me come to the specific resistance profile of dolutegravir. What we have learned from a huge data set of the registrational trials in treatment-naive patients for dolutegravir is, in the very unlikely event that you fail a therapy with dolutegravir virologically, you will not develop a integrase-resistant mutation. It has never happened up to now in any of our registrational trials in the treatment-naive patient population. That is very important to know. What is even more or as important to know is that also the so-called nucleoside analog backbone was protected by dolutegravir. As you can see here on that slide, there is a number of zeros here. The 0 indicating that failure, if it occurs in rare occasions, it occurs with 0 resistant mutation to integrase, but also to the nucleoside analog backbone if in the dolutegravir arms. This is different clearly from the efavirenz-based regimen in the single trial, where you see that not only NNRTI resistant but also nucleoside analog mutations can occur. This is different from the Spring 2 trial, where you can see in direct comparison to raltegravir that the barrier to resistance development for raltegravir was lower in this setting compared to dolutegravir. And what you can say is that in the Flamingo trial, which is the direct comparison of dolutegravir to a darunavir boosted regimen, what we did see is that the development to resistance was as unlikely to happen in the dolutegravir arm as with a boosted PI. So let me summarize these complex data set by saying, where do we place dolutegravir in the naive patient segment today in terms of resistance development? I think it's fair to say from this data set that the barrier to resistance is more in the range of a boosted PI than it is in the range of an NNRTI. So clearly dolutegravir proved to have a high barrier to resistance. This is another study which has been published recently, which is the ARIA study, comparing a dolutegravir-based regimen versus atazanavir boosted only in women. And as you can see here, another study showing superiority for dolutegravir over a boosted PI. And you can see here that this is not only true for the intent to treat, but also for the protocol per protocol analysis. And if you do the sensitivity analysis, you see that clearly the combination of dolutegravir bacavir 3TC was superior in this combination in this study compared to atazanavir boosted regimen. Now, in this study, again, comparing dolutegravir with a boosted PI, very few patients failed virologically. And if you do a resistance analysis, what we do see is that treatment-emergent mutations in patients with confirmed virologic withdrawal in this ARIA study was not happening in dolutegravir, and only very few, actually only one patient failing with an NRTI mutation in the atazanavir arm. Clearly indicating again that the barrier to resistance for dolutegravir is comparable to what you see with the boosted PI. So that was all studies in treatment-naive population. How does it look in treatment-experienced population? Now we do have one study, just to remind you, which is called SAILING, which is a registrational study performed in treatment-experienced patients who were naive to integrase inhibitors. And here dolutegravir outperformed raltegravir, having a response rate at 48 weeks of 71% in dolutegravir arm versus 64% in raltegravir in pretreated patients. Pretreated patients, again, who have never been exposed to integrase inhibitors. Now, if we have a look into those patients who failed in this trial, in this, treatment-experienced patient segment, what we do see is the proportion of subjects with evidence of an integrase resistance was significantly lower in the dolutegravir arm compared to raltegravir. And on top of that, what we could also see in this trial, what is not shown on this slide here, is again that also dolutegravir somewhat protected the backbone, which were in the majority of cases nucleoside analogs. These data, together with the data of in vitro studies, suggest that dolutegravir has a higher barrier to resistance than the other integrase inhibitors, namely raltegravir and elvitegravir. So not all integrase inhibitors are created equally with regard to the resistance development. And this is basically shown on this slide here. What is shown is that basically you have two pathways, major pathways, to develop resistance to integrase inhibitors, which is the 148 and the 155 pathway. And as you can see here, even if you combine the 148 and 155 mutation, the susceptibility to dolutegravir is only decreased marginally, I would say, in comparison to raltegravir and elvitegravir. So in other words, even in those populations where you do develop integrase resistance, even in the presence of integrase-resistant mutations, dolutegravir still remains partially active. And this actually is also shown in the clinic in a Viking study, and the Viking study was done in actually very heavily treatment-experienced patient populations who have failed on an integrase inhibitor-based regimen before. Here, what we could show is that in this non-comparative study, which was open label, dolutegravir actually maintained antiviral activity in a large proportion of patients who have been failing after a prior on another integrase inhibitor, even in the presence of some of the resistant mutations. And you can see here the response rates, which we have never seen before. So having seen these clinical data, the question is, what are the underlying mechanism, what is the underlying mode of action which makes dolutegravir different from elvitegravir and raltegravir with regard to the development of resistance? So what we do know is that the molecule dolutegravir is fitting very well into the groove of the enzyme. And once it binds to the substrate, which is the integrase, it sits there for a very long time, and it sits there very tightly. And this actually is depicted on this graph here, showing that the dolutegravir dissociation rate from the integrase DNA complex is much slower compared to raltegravir and elvitegravir. Actually, it sits there 8 times longer than raltegravir and 26 times longer than elvitegravir. So the combination of multiple raltegravir and elvitegravir signature mutations are needed to really decrease the efficacy of dolutegravir. And this is one of the reasons why we do believe that dolutegravir has such a special resistance profile, and why do we believe that not all integrase inhibitors are created equal. The second reason why we do believe that dolutegravir has such a good resistance profile is that it has such a predictable and consistent PK profile. So what is depicted here is after a single pill intake of dolutegravir, we measured the trough level after 24 hours and compared it to the IC90 of wild-type virus. And what you can see here is in the dotted line above the x-axis, indicating the IC90 of wild-type virus, and the 24-hour trough level after a single pill intake of dolutegravir, that there is a huge cushion of safety. Actually, this was 20 times higher, the concentration after 24 hours, above the IC90, which is seen with a single pill intake of dolutegravir. So the combination of both, the tight binding and the long binding of dolutegravir to the enzyme and the favorable PK profile, both in combination, we believe make it so special with regard to the development of resistance. So finally, let me end up with the last slide showing a comparison of the PK/PD profiles of dolutegravir versus elvitegravir and raltegravir. What we do see actually is that we do have a considerable half-life, which is longer for dolutegravir and elvitegravir boosted with compared to raltegravir. We do have a low to moderate PK variability for dolutegravir in comparison with the other two. We have a high protein binding. We do have, and this is perhaps the most important thing, a very well-established PK/PD relationship for dolutegravir, which we did not see to that extent with raltegravir or elvitegravir, at least only if it's getting given boosted. So, taking all this together, I think it's fair to say that dolutegravir is a very special drug, not only in terms of convenience, of antiviral potency, and with regard to drug-drug interactions, but also it's a very special drug with regard to the protection of development of resistance. And this actually was shown in the clinic. We do have a clear biological mechanism underlying this, which we can explain. And this is actually not only true in the naive patients, but also in treatment-experienced patients, both with integrase or prior integrase failure and not. Thank you very much for your attention. That was a lot of data compiled in a very short time and very condensed. I hope you could take one or the other new or good information for you. And your local representative will be very happy to guide you with any other remaining questions, or even you can call up me. Thank you very much.